You might well ask, what the hell is a paediatrician doing talking in a melanoma conference? Which is exactly the question I asked Imogen when she phoned me up to give this talk. But hopefully there's stuff that you can learn, and there's certainly stuff I can learn from you. So I'm a paediatric oncologist. I work at the Birmingham Children's Hospital. To use Simon's analogy, perhaps the slightly more acceptable face of the West Midlands. And being a lifelong Chelsea supporter, I don't give a stuff how many teams there are in Birmingham. So just a bit of background about childhood cancer. It's rare. And when we talk about children, we're usually talking about the age range 0 to 14, 0 to 15. It only makes up about 0.5% of all the cancers that we see in the UK. That roughly translates to about 1,500, 1,600 newly diagnosed cases of cancer in kids each year. And of course, the spectrum of disease that we see in children is completely different to the spectrum of cancers seen in adults. And here's just a table or a graph which shows you the various frequencies of the sorts of tumours that we see in children. And in fact, the commonest tumour that we see in children is leukemia, acute lymphoblastic leukemia in the main. Makes up about 1/3 of all of our diagnoses. You will see here carcinomas and malignant melanomas does make an appearance on the graph, and I'll talk a little bit more about that in detail in a little while. I specialise in some of the even rarer cancers, so 2 of the tumours that I look after in Birmingham are cancers of the eye, so-called retinoblastoma, and liver tumours, hepatic tumours. And I'm also a drug developer, so one of my other areas of interest is in new targeted therapies for paediatric cancers. Paediatric oncologists always like to crow about their successes, and I'm no exception to that. But this basically shows you how the survival of childhood cancer has improved over the decades. So the bottom line here is kids who were diagnosed back in the 1960s. So here I will declare my age to you, although slightly veiled. So this is my sort of childhood era. So, for example, had I, as a child, been diagnosed with our commonest tumour, acute lymphoblastic leukemia, my chances of cure when I was 7 years old would have been about 10%. Today, the chances of curing a 7-year-old with acute lymphoblastic leukemia are nearly 90%. So in my lifetime, which I know I've got lots of grey hair, is surprisingly short, we have seen a revolution in the management of childhood cancers. And it's been an amazing experience to be part of that really exciting development. One of the things that we have been good at, I think, in paediatrics is actually recruitment of patients into clinical trials. So the vast majority of kids, when they walk through the door, are recruited into a frontline clinical trial with their first diagnosis. And again, leukemia is the paradigm here. Over 90% of leukemia patients at presentation recruited into clinical trials. Clinical trials are good for you. There's lots of data out there in the medical literature which shows that overall, over a number of years, patients who are recruited into clinical trials have better outcomes. We learn the best treatments from clinical trials. We give those best treatments to the patients in the next clinical trial, and constantly improving and improving and improving. So what about melanoma? So yes, it's incredibly rare. The latest data that I showed you suggests that, it's back. The latest data suggests that it's about 60 cases fall into that other epithelial and malignant melanoma. But if you go into it in a little bit more detail, there are only about 10 cases of malignant melanoma in childhood in the UK per year. The survival rates are thankfully very high. Back in the early 2000s, we were talking about at least 3/4 of patients surviving. That is now as high as 90%. And these statistics are published very recently by NHS England. So here's my personal experience of managing malignant melanoma, which is sketchy. In the Children's Hospital in Birmingham, we see about 1 case of malignant melanoma every 3 or 4 years. Fortunately, most of those cases are local, confined to the skin, very, very, very rarely have spread to nodes or metastasized. And in my entire career at the hospital, over the last 25 years or so, we've only given systemic therapy to 1 patient with malignant melanoma. And that was back in the day when interferon was useless. So what can we do for these very ultra-rare tumours? And I'm not going to focus any more specifically on melanoma, but I will talk to you about some of the things that we've been able to do because we are dealing with a whole variety of rare tumours. I've shown you by definition, pretty much everything we do is rare. So how do we succeed? How have we managed to increase those survival rates? So one of the really important things has been the establishment of national centres of excellence. So we recognise that for some of these sorts of conditions, the eye cancer, bone cancer, liver cancer, proton radiotherapy, you can't or you really shouldn't be delivering that across 100, 120 hospitals across the country. Why not? Well, most of that is driven by what I would call local therapy. It's not the oncologist. Any fool can be an oncologist. Living example. We can reach into the pharmacy and grab a drug just like that. It's mainly driven by the so-called local therapies. So for the eye cancer, it's actually having specialist access to the surgeons who can laser the back of the eye and do incredible stuff at the back of the eye. For bone cancers, it's the same. It's largely around very, very specialised surgery. And what I would say for childhood melanoma is that local therapy already exists. It doesn't necessarily need a single centre in the country to deal with paediatric malignant melanoma because it already exists in the adult skin MDT. So what are the other things that we can do? As I said, the need for systemic therapy in childhood malignant melanoma is vanishingly rare. But here's an example where, because it is so rare, here there may be an argument for there being a single national centre that does specialise in the systemic therapy for malignant melanoma in children. Ideally situated, co-located within a very active adult skin oncology MDT. We definitely have links to the international expertise, and increasingly our platform works across Europe and across the world, not just in the UK. We certainly have access to novel therapies and clinical trials. I work in a European network of drug developers where we are delivering and have delivered new targeted therapies to children, and we're constantly developing those strategies. And many of the drugs that you have heard about today, forgive me, I'm not quite sure why we have got into the habit of naming drugs with impossible names like ipilimumab. What's wrong with aspirin and stuff like that? Anyway, I digress. So we do have access to these drugs, and we have tested drugs like pembrolizumab, ipilimumab, dabrafenib, trametinib. All of these are currently under investigation in childhood, not necessarily only in melanoma. We certainly have an increasing access to genomic medicine and personalised medicine, which is a very important thrust for adult practice as well as paediatric practice. To be honest with you, I think it's probably rather an overinflated excitement within paediatrics, because what we find in children is that children actually have very, very few genetic events in their cancers, unlike adults. So the ability for us to detect anything interesting or targetable with a drug is very, very limited. But where it can be detected, it's often very informative and very useful. And I hate saying this. As a paediatrician, I've spent my life telling medical students that children are not small versions of adults. However, with malignant melanoma, I think I can be forgiven for saying, actually, there's no reason why you shouldn't treat an 11, 12-year-old with malignant melanoma in exactly the same way you treat an adult with exactly the same therapies. So I'm going to give you a couple of examples of the networks that we've been working with. So this is one which is called the European Reference Network. This is the Children's Cancer European Reference Network. As it says, it is pan-European. It's been funded by the EU. Despite Brexit, we're still allowed to be part of it. And we are one of 3 hospitals that is an expert reference centre within this network. And it specifically looks at providing what we call cross-border access across Europe. So some of the countries who don't have expertise, helping those patients move across borders to get that expertise. We have a number of tumour boards which are virtual, so we share information electronically, scans, pathology, etc. We have a big resource, and we have parents and patients on our executive board to provide information. And specifically and relevant for this group, we have a rare diseases work stream. So we do have a group of clinicians, parents, academics working together to answer some of the challenging areas around rare diseases. In terms of clinical trials, I did a quick survey of something called the ECMC. This is the Experimental Cancer Medicine Centre website. So these are the centres in the UK who are doing novel, innovative, first-in-man, phase 1, phase 2 type clinical trials. And much to my surprise, there are 60 open trials in malignant melanoma in the UK. Or not specifically for melanoma, but studies or trials that melanoma patients could potentially be recruited into. If you look at the number of those studies that are open for children, there are 12 studies where children, 0 to 18, could potentially also be recruited. But here's one of our problems. That's quite exciting. We've got 12 clinical trials that we can recruit children into. But as I've said, the number of kids who actually need the systemic therapy is vanishingly rare, perhaps 1 or 2 cases a year. How do I choose? How on earth do I choose which of those 12 studies to put my patient into? And the problem we've got is if you keep putting individual patients into 12 different studies, you'll never learn anything. We need to coordinate, and we need to prioritise, and we need to say, all of the children should be going into this study. So even if we only have 5 or 6 children in that study, we learn a lot more than having them spread across the whole portfolio. And what I don't know is, are there some really exciting things out there in the 60 that aren't available to children? So one of the things that we've been pushing for, particularly for conditions like melanoma, is to reduce the age eligibility. So most of the adult studies will refuse to take patients under the age of 18. Well, if I'm 14 and I've got a malignant melanoma and I need systemic therapy, why on earth shouldn't I be allowed access into an adult clinical trial? And so one of the things that we've set up is this thing called Accelerate. And one of the rationales for Accelerate has been around drug development. So many, or really all of the drugs that we use in children have been developed in adults. And it's based on disease, which has meant that there's relatively poor access to paediatric patients. So if a drug company is developing a drug for breast cancer, they will say, breast cancer doesn't occur in children, we don't need to give this drug to children. But we don't know whether that drug actually may have some interesting activity in the rare tumours that we're dealing with. So we've been pushing for there to be a complete change in the paradigm. So rather than a disease-specific drug development program, it's target-driven. So if the target, BRAF, for example, is present in my paediatric population, why shouldn't we be testing BRAF inhibitors in children as well as adults? And there is some movement on this platform. And so one of the unique things about Accelerate is that it's a multi-stakeholder organisation. And so we have a rather unique experience of working with patients, parents, the academics, the paediatric oncologists, haematologists, the pharmaceutical industry, and the regulatory authorities, so the European Medicines Agency. Previously, we were sort of accused of all working in silos, but now we have had 2 or 3 meetings where we're all coming together, all trying to speak the same language and trying to move this agenda forward. But of course, the flip side of this is where there is overlap with adult cancers. Currently, if you're a drug company, you have to, and we say, yes, well, this condition does also, albeit rarely, occur in children. The drug companies are now mandated to do studies in children, this so-called PIP, Paediatric Investigation Plan. So we've got this crazy situation in Europe where in conditions like non-Hodgkin's lymphoma, which of course is an adult and a paediatric disease, we currently have about 10 compounds in development in Europe, and the companies have been mandated by the European Medicines Agency to do children's studies in all 10 drugs. Now there are less than 20 kids relapsing across the whole of Europe with non-Hodgkin's lymphoma who would be eligible for a clinical trial. How on earth are the drug companies expected to do 10 studies with so few patients? And so one of the things Accelerate has been able to do is to come together, regulators, pharma, academics, patients, to actually push to say, this is nonsense, and there needs to be some prioritization of the portfolio. I'll just skip over those because I've said. Academics love this. Writing papers. That's what makes you a professor. Writing papers. The papers we usually write are stuff that you've already heard. Does blogomycin work better than bim bama blogger thing? But actually, we occasionally also do stuff like this, which is actually writing statements or viewpoints or political statements around structures within health services around Europe. And this is something that we published on the Accelerate platform around drug development and how we should change the paradigm from being disease-driven to target-driven. Within Accelerate, we have a number of working groups. I'm just going to highlight this one, FAIR, Fostering Age-Inclusive Research, which is going back to what I said earlier, is trying to break that age barrier. There's pointless having an age limit at 18. Bring it down. Let's bring it down. And so, again, we have published in the medical journals about our aims and our multi-stakeholder enthusiasm with the drug companies and with the regulators to push this age agenda down. And we now have these sorts of paradigms where we're looking at whether or not there are similar targets present across all age groups, in which case, if there is a target across all age groups, we should be doing studies across all age groups. The one that's particularly relevant to malignant melanoma is this one here, is where there is an adult disease which occurs very rarely in the childhood or adolescent population. Then again, the push here is to not have age-exclusive trials, but to have age-inclusive trials. Break those barriers completely and say, if you've got a melanoma and you need a targeted therapy and you've got the target, if you're 12, for goodness sake, let's give it. I'll skip over that one. And again, we have written papers here on our drive to have this targeted approach to therapy. So these are my last two slides, just my conclusions. So as paediatric oncologists, we are used to working in this rare diseases arena. Everything we do is rare. And I hope I've been able to show you in those first few slides that despite working in that arena, we've not done too bad a job. We have in the UK, fortunately, got a very strong national infrastructure, specialised infrastructure for delivering clinical care in childhood cancer. And trial participation is very much standard of care. It's not exceptional, it's very much standard of care for us. But I think we've also started to recognise that where necessary, there are some specialist skills and access to new techniques and technologies that are super rare and would benefit from maybe a single expert centre in the UK. And then for melanoma, my conclusions are here. This is my last slide. So in the main, I think I would encourage us to say that despite sticking in my throat a little bit, this is a tumour where the expertise exists in the adult MDT. It's pointless sending me a child with malignant melanoma. I hardly ever see it. Let's get them treated in the right place. There's a lot to still be done, even within the adolescent and childhood population, about risks. I think the rapid access to experts works reasonably well through the GP 2-week waiting, but certainly my practice at the Children's Hospital is that those come into oncology. We just farm those straight out to my paediatric dermatology colleagues. And as I've said before, the access to systemic therapies is such a rare entity that I think it does demand us to look carefully at a single national centre. So I think that was my last slide. Thank you.